it's not the end of the world to have heart disease. I mean, there are some things that are very treatable. There are some, you'll see from my talk, there are some common rhythm abnormalities that still need quite a bit of work in terms of trying to sort them out and trying to find the best treatment for them. But it's not the end of the world, and a lot of different rhythm abnormalities that some of you probably have are treatable, or we can at least suppress the symptoms. So I'm going to give you a little bit of an overview. I'm actually here representing in part my cardiology colleagues who are electrophysiologists as well. We have two at the International Heart Institute, and for the most part, a lot of the treatment for rhythm abnormalities don't require surgery, which is good. And so they're able to treat these either with medicines or other types of ablative procedures that don't require surgery. So I'm going to give you a little bit of an overview. It's a little mini cardiology lesson in rhythm abnormalities. This is a depiction of the heart just to show you the flow of blood, so you understand. In order to understand a little bit about what I do, you have to understand a little bit of anatomy. So blood comes back to the heart on the right side, because the heart's divided into the right and the left side. Blood comes back to the right side, which is depicted by the green arrows, goes through the right ventricle, which is the pumping chamber that pumps the blood to the lungs. And once the blood gets to the lungs, it gets its oxygen, it drops off carbon dioxide, and it comes back to the left side. And particularly when we talk about atrial fibrillation, which is the most common rhythm abnormality we see, especially as we get older, a lot of it has to do with what's going on in this filling chamber on the left side, depicted by the red arrows. But then the blood goes into the red pumping chamber here, which is the left ventricle, and then to the body. Now, the electrical system of the heart starts about here by this little white dot, and that is the SA node, which is sort of the center that controls the propagation of electricity through the heart muscle, which is how you get it to contract. And it propagates, I mean, this is greatly oversimplified, of course, but it propagates to another center, which is about here, right in the middle of the heart. And there's something called the AV node there, which is another sort of center where the rhythm gathers. And then it propagates down through the muscle from there, through the pumping chambers part of the muscle. And you can have abnormalities. I'm not going to talk so much about the abnormalities that are a little less common, but that have to do with blocks along the way here. And they occur not infrequently as well, but if you get a block anywhere along the electrical pathway, if it's going to slow down your heart rate significantly enough, you're going to end up needing a pacemaker. And so the treatment is pretty well standardized. There's no drugs you can use for that. You need to use a pacemaker to sort of replace your electrical system and drive the heart rate back up. But I'm going to talk about fast heart rhythms because there are a lot of more different treatment modalities, and actually some of these are much more common than developing a block in your heart rhythm without having any other heart problems. Actually, the most common rhythm disturbance is it's really not a true rhythm disturbance because there's no treatment necessary for it, and that is extra beats, premature beats, and they can be generated from the filling chambers or those pumping chambers that I showed you. So some people, if you feel your pulse, it may at times be a little irregular. Some people will have these extra beats every 6 seconds, for example, but almost always they're benign. And we don't actually do anything to suppress them or treat them. But it may be concerning to you to feel that your pulse is a little bit irregular from time to time. It's easy to tell if it's extra beats almost always because your pulse is regular most of the time, and every every occasion, maybe more commonly it's 30 to 60 seconds, it's a little irregular. That suggests just an extra beat. These rhythms are a little more complicated. Now these four I chose because they're perhaps the most common ones we see that originate from those filling chambers. This one comes from the pumping chambers and is much more serious and likely and luckily a little less common. But occasionally we have patients who present with this and haven't necessarily passed out, but have the symptoms that I'm going to go through with you, which are the same as you might experience with these rhythms. But these are rhythms that often come and go, and so patients have intermittent symptoms related to these. And these are fast rhythms, as I said, that come from the filling chambers. WPW actually is not an uncommon rhythm that occurs at a younger age. It's called Wolff-Parkinson-White syndrome, and it's a fast rhythm. It's intermittent, and it's one that we tend to see earlier on in life. This stands for AV. Remember, I told you about the AV node, not the SA node, the main one, but the AV node in the middle of the heart. This is an AV node reentrant tachycardia, which just means that the electricity is going around in a circle like this instead of propagating down through the heart like it's supposed to. And that reentrant, continuous circle is causing the heart to beat very fast. And that's a fairly common rhythm disturbance, at least that we see. Atrial flutter, in and of itself, is probably not as common. It's still, though, a fast rhythm, and it needs to be treated because it can often be symptomatic. And atrial fibrillation, as you see, because I'm going to focus mostly on atrial fibrillation, it is particularly common as we get older. The symptoms, like I said, are pretty similar. I mean, it doesn't matter which rhythm you have. If you are going to have symptoms from it, these tend to be the most common. Probably palpitations and shortness of breath are the most common, but you can also get dizzy and feel like you're almost going to pass out, and fatigue comes with it very commonly as well. And the worry is if these fast rhythms are intermittent, and when I say intermittent, I mean it could still go on for days and you'd probably be safe getting it treated. But if it goes on for weeks, the risk is that fast heart rate will cause the muscle to tire, and then you can go into heart failure. And so that's why these rhythms, when they persist for a prolonged amount of time, they need to be treated. Those first two in that list of four that require treatment, this WPW that we see in younger patients and the AV node reentrant tachycardia, there's really three options to treat these, and it's in this order. Actually, WPW either needs medication or ablation. The vagal maneuvers are for AV nodal reentrant tachycardia. It's not a permanent solution, but a lot of the patients that have this rhythm disturbance, AV node reentrant tachycardia, can use a bearing down vagal maneuver and cause the rhythm to stop, which is at least a very simple way to get it to stop if it's not occurring very often. Of course, if it becomes more frequent, then you're going to need something to suppress it, and that's where the medications come in. So most often we try with medications first, because if you can use medications to suppress it, you've solved the problem without having to do a procedure. Luckily, with these rhythm abnormalities, though, there is an ablative procedure that is highly successful, which, as you're going to see, that's not always the case. But in these particular rhythm disturbances, ablation is highly successful. And so if patients are having recurrent problems, especially on medication, they end up having an ablation procedure, which is a cath lab procedure done through the groin and is a pretty low risk. Well, Flutter, I mentioned that flutter is not as common, but we do see it, and one of the main problems with flutter is that it can often degenerate into atrial fibrillation. The symptoms are the same. The treatment options are almost the same, except that the way to stop the flutter, instead of that vagal maneuver, that bearing down, the way to stop the flutter here is a little more complicated. You have to be put to sleep for just a minute, given a strong sedative, and then receive an electrical shock. And that shock will shock the rhythm back to normal. And then we use medication to keep you out of that atrial flutter. Again, though, not all flutters, but most flutters have a very high success rate with ablation. And so, again, with a relatively low-risk procedure done by my electrophysiology colleagues, you can undergo an ablation if needed, especially if the medications are not working, and it's highly successful for almost all flutters. Because the flutter wave can come from different parts of the heart. Some of them are a little more complicated than others, but the most common type is very easy to ablate. Well, a little bit more about atrial fibrillation, because this is right now, between the electrophysiologists and the surgeons, this is our biggest challenge. I mean, this is what we're focusing a lot on trying to treat, because we have the least success in treating it and because it's the most common arrhythmia that we see. One of the main reasons we're interested in trying to treat this problem is that it has significant consequences. I mean, if it were a rhythm disturbance where even if we couldn't get rid of it, it didn't really affect you very much, then we'd probably just leave you alone. And in fact, there's been some arguments for leaving patients in atrial fibrillation, making sure that you treat their risks of being in atrial fibrillation, which means you don't want their heart rate to be so fast that they go into heart failure. You need to put them on blood thinners so that they don't get strokes. But some people believe that all you have to do is leave patients in atrial fibrillation and stop worrying about trying to get them out of atrial fibrillation. But there's a lot of good data out there that says that that's probably not a good idea. And this is part of it, is that there is some danger to it. The stroke risk for patients in atrial fib is increased 3 to 5-fold over the general population of the same age. The mortality is increased 2-fold, and this is a little bit. Has been argued a little bit because one group showed that the risk of death with this rhythm disturbance is not that significantly elevated. And so that got a lot of attention, again, because people said, well, why should we bother? Why don't we leave patients in atrial fibrillation? Well, there's a lot of information that says, no, you are at increased risk. The medicines that we use have side effects. Some of them are pretty significant. I mean, it makes the drugs completely intolerable. In fact, the irony is that the drugs that have the most success in treating these problems are the ones with the worst side effects. So naturally, there's a lot of work being done to develop new drugs that have less side effects, which would also be great. And we're moving forward in that direction as well. But the cost also is significantly elevated because patients end up in the hospital fairly frequently with atrial fibrillation. Well, here you can see that this is clearly a disease towards the end of our life. If you look at the age span across the bottom there, the general population follows this red curve, and the incidence of atrial fibrillation follows the blue bars. So you can see that very, very few people have atrial fib below age 40. But as we reach 40, it starts to increase. And the peak is somewhere in the 70s. Here again is another way to show you why this tends to be a big problem. If you compare patients with medical problems and AFib compared to without AFib, there's a 65 to 126, depending on what you read, because there are several different studies on this. But there's a 65 to 100% increase in your risk of stroke. Mortality risk increases at least 50%. If it's not twofold, it's at least 50%. And hospital costs are significantly increased as well. Well, when it comes to atrial fibrillation, these are some of the same symptoms I showed you for all those rhythm disturbances, but this just puts it in terms of how frequently we see their symptoms. So 60% of patients who have AFib describe shortness of breath, half of them describe palpitations, 40% fatigue, and then some other symptoms including dizziness, which I mentioned before, are a little less common. Well, because this is a common problem and because there's already been a lot of work to try to figure out how to solve this problem, there are a lot of different alternative therapies out there to try to treat atrial fibrillation. If you look at the way this graph is set up, here on the y-axis, this is market acceptance, which means, when I say market, I mean patient, doctor, anybody who is in the, is around atrial fibrillation. The general acceptance versus, on the x-axis, the clinical efficacy. I would argue probably that catheter ablation falls further along here now. This is an older slide. But as you can see, drugs are at the top of acceptance, meaning that both patients and doctors will prefer to have drug therapy before they have some sort of procedure for atrial fibrillation. So it has a very high acceptance rate, but the efficacy is not that great. And one of the main reasons for that is that in a high percentage of patients, the longer you're in atrial fibrillation, I mean the longer in terms of years that you're dealing with atrial fibrillation, if you're going in and out, the more you will have it frequently. You may even go from having it intermittently to having it all the time. So the drugs start failing over time. So it's not just a matter of how successful the drugs are initially to treat, because often initially they're very good, but they fail over time. So it's not a very good long-term treatment. Catheter ablation is a good long-term treatment. It's not 100% successful, but then none of these things are 100% successful, which is what is driving us to continue to work at it. But it's reasonably successful, and it's getting more and more successful with technology that's being developed by these electrophysiologists to do these catheter ablations just through a puncture in the groin, in the cath lab. The problem is that few electrophysiologists take this on. They're very long procedures. They can last up to 8 hours. So you're in the cath lab the whole day, very often under general anesthetic, which brings it a little bit closer to surgery. You don't have the incisions to deal with, but you're under general anesthetic, so you're not moving while they're trying to map the inside of the heart to figure out where to do the ablation, where to burn the abnormal rhythm. And so a lot of electrophysiologists who are busy have a hard time committing a whole day to this one very, very long procedure. And so it's gaining acceptance, and of course, along with that, the times to ablate are getting shorter and shorter. Some docs are doing these cases quite easily in 4 hours, so the times are coming down as the docs get better and the technology gets better. And that's why I think it probably should move out a little further in terms of efficacy. The only other one I wanted to mention to you to draw your attention to is the Maze procedure, because that's our surgical procedure, and that was developed through the 90s by a man named Jim Cox, who was a heart surgeon in St. Louis, and he developed a surgical procedure that actually had a very high success rate, showed it in a series of 400 patients. The problem is, of course, it's very invasive. His initial procedure required that you go through the front, a usual chest incision for heart surgery, that you go on the heart-lung machine, that your heart is stopped, and that's a big deal. I mean, that's a major operation. And so you can see that obviously is very low on the acceptance scale. But it at least was the start for us to prompt motivation to look for a better procedure for patients. Another reason why we're looking for better ways to treat these patients is because if this slide looks confusing, it's meant to be. I mean, this is the problem with atrial fibrillation, is that patients with atrial fibrillation bounce all over the place in terms of their treatment. I mean, they may get atrial fib, start with drugs, and then they need an electrical cardioversion, a shock, that gets them out. But then they go back on their drugs, they fail, they end up with cardioversion again, and then it leads to a change in drugs. Somewhere along the line, they may get a little unhappy, see a different doc, because it's really frustrating. They get on blood thinners because of the stroke risk, so you got to prevent the stroke risk. And then somebody talks about a catheter ablation, somebody else says maybe surgery. I didn't go into the devices on the list there, but there are devices that you can use. Some of them are uncomfortable. Others have limitations, like a pacemaker has limitations, but they're out there. I mean, there are other different therapies, but it's very confusing how to manage patients. And if you look at the American Heart Association guidelines and you follow these decision trees to try to decide how you're going to treat atrial fib, particularly the longer that a patient has it, it almost all boils down to one drug that has the highest efficacy, but again, remember I told you the highest side effects as well, or an ablation procedure. And as I said, these ablation procedures are becoming more and more successful. I mean, the success rate with a catheter ablation is somewhere between 60 and 80%, and the success rate with surgery for defined patients, for a certain patient population, is somewhere between 70 and 90%. So I wanted to spend a little bit of time telling you about the catheter-based treatments and the surgical-based treatments that we're doing here at St. Pat's. Well, again, you remember I showed you the filling chamber that had the red arrows on the left side. That's our main focus in atrial fib. Now, this is a lot more complicated for patients that are always in atrial fibrillation. I mean, we're working towards treating patients like some of you who have atrial fibrillation all the time. But these success rates, I mean, we got to start somewhere, and we start where we have a higher success rate, which is for patients who go in and out of atrial fibrillation. Well, it turns out that a lot of the focus for that is around these pulmonary veins where the blood comes back from the lungs and goes into the left-sided filling chamber. And so that's where our procedures are focused. And then the other thing that's come along more recently is that we have a lot of particularly autonomic nerves, a certain type of nerve set that transcend down through the body to control certain functions. And these nerves have been shown to innervate the heart as well. And what we found is that they can be implicated in atrial fibrillation as well. And we have a way that we can test for this and then ablate those nerve centers that are down by these pulmonary veins, which can help increase the success of the procedure. So really, briefly, between the catheter procedure and the surgical procedure, because we use both. I mean, some patients are better suited for one, and some patients are better suited for the other. So we use both. Again, we do start with drugs, but we're looking for patients who've had atrial fib long enough that the drugs are not working as well anymore and starting to fail. And if you're having symptoms of AFib and the drugs are not working, then that's when we start talking about an ablation procedure. This one is performed from the inside as opposed to the surgery, which is from the outside. They both have their advantages and disadvantages, which is why we're using both. The mapping that is done is very high tech, and that sophistication, I think, is what's helping make the catheter procedure more successful. The problem, of course, is that there's indirect visualization because you can't see inside the heart. The catheter is inside the heart, and you have to use other techniques to find out where to burn out that abnormal rhythm. And so that energy used to burn out that abnormal rhythm is from the inside instead of the outside. Those pulmonary veins that I showed you that enter that left-sided filling chamber, they have to be isolated because that's where a lot of the atrial fib comes from. So this procedure involves ablating and isolating those pulmonary veins away from the heart so electricity can't get into the heart and start atrial fibrillation. And another advantage of the catheter procedure is that the electrophysiologists have found that there are certain hot spots on the inside, which we as surgeons actually can't test from the outside. Those hot spots on the inside can be burned out if they're found through the mapping procedure. Well, as I told you about the surgery, it was not going to be acceptable to patients and doctors to do a major surgery for this through the front on the heart-lung machine. So we had to do something else. So the first thing we said is we got to figure out how to avoid the heart-lung machine. Let's not stop the heart. The second thing is how do we do this through small incisions so that patients don't end up having a big incision through the chest. So we're working through that, and actually the incisions are getting smaller, the procedure is getting shorter, and we are trying to work towards, on the horizon is a procedure to work through just a small hole, to access the heart on the outside through one small hole. And then do the testing and ablating that way. Again, though, what we're looking for, what we use ablation for, is patients who have trouble with the drugs, either side effects or they're not working anymore and having symptoms. And again, it's on the beating heart. We need to see from the outside because we see exactly where we want to put those burns. And we use bipolar energy. I didn't go much into the energy sources, but there are different ways to create the burn, some more effective than others. This happens to be the most effective so far. But it's delivered instead of from the inside, from the outside of the heart. So we don't go in. And the components, we can't find those hot spots like the cardiologists can. But what we do is we map those where those nerves come in. So where those nerve bundles can affect atrial fibrillation, we can burn those from the outside. And the last thing we do is that we remove the left atrial appendage. I didn't go into that very much, but it's simply it's the main culprit that causes stroke. It's a little blind pouch. It's like the appendix. When your appendix gets infected, you get appendicitis, it's got to come out. This is a blind pouch like the appendix, and it's called the left atrial appendage. If blood clot forms in there, that's where the risk of stroke comes. So because we're on the outside of the heart, it's very easy to remove it. But what some of you might be figuring out, because this is what the surgery looks like, so it's not perfect. You still have to have incisions, and you still have to go through even though it's a much smaller surgery, you still have to have surgery. And so what you might see is that where we would love to go with this, and I think this will come sometime in the next maybe 5 to 10 years, is that we need to collaborate together. We need to work together, meaning that some of the work has to be done from the inside and some of the work has to be done from the outside. And if we can get the procedure down to avoiding these incisions, and there's just one access through a hole to the outside of the heart and one access with a hole to the inside of the heart, we can take care of all of the possible causes of atrial fibrillation. So that's where we're headed. We're not there yet, but it's going to require a collaborative approach. So these are my two electrophysiology colleagues, and I told them that they needed to be recognized as well, because one of the nice things about our program here is that we work very well together, and so we are in the midst of developing a more comprehensive program for atrial fibrillation by working together. Thank you.
Our institute was founded in 1995, and these people, George Dennison, the president of the university, Larry White, the then CEO of this hospital, Jim Mowry and Carlos Duran, two formidable surgeons, sat down and said, we can do something more than just pursue our own interests. We can do something to pay back to our state, our cities, and our universities. And they formed this collaboration to promote excellence in medical care. That is Dr. Duran. He is, by most counts, one of the premier surgeons to ever walk the face of the earth, at least in heart surgery. We owe a tremendous debt of gratitude to him, and he inspires us daily to do something new, to do something better. He pioneered much of the techniques and technology that allows us to achieve the kinds of results we achieve today on a regular basis, and a huge debt of gratitude is owed to him. This is a little bit of his legacy here in Missoula, Montana. This is what this guy did, this is what this collaboration did, and we take it quite seriously, our responsibilities. Mitral valve repair was Dr. Duran's primary interest, although he was very interested in many things. And he pioneered some approaches that we have then since refined some and learned as best we can, and opened up an expansive array of techniques to save lives and promote people's health and well-being. It's useful for us to remind ourselves as physicians and surgeons that not everything we do, although we set out to achieve something great, not everything we do is without cost or disability or injury to the patients. Many of you have heard about the Institute of Medicine's report in 2000 that 100,000 patients a year, people a year in the U.S. lose their lives because of either medical mistakes or inadequate medicine. Now that's not just murder. That's not somebody going to the hospital and a mad doctor shoots him in the head. These are typically well-intentioned people practicing the best that they can and making some errors. Those kinds of errors need to be systematically eliminated, and I'm not going to talk to you about those things. But some of the things that we encounter are natural obstacles that are necessary to inflict pain or suffering or some collateral injury, if you will, to achieve cure. Heart surgery is such a discipline. I want to go back for 1 second. Does anybody know who this is, supposedly? This is supposedly Hippocrates. Bloodletting. Bloodletting. It is a term iatrogenic, which is iatros, meaning formed in hospitals. Iatrogenic injury, which is related to getting medicine that we thought would do better and having been injured by that. And we're keenly aware of those things. Access to the heart, as in life, is a little bit tricky. Anybody recognize that? Looks like what? Somebody? It's Flathead Lake. Yeah. The satellite vision of Flathead Lake with all of the things that we know are man-made taken out of it. There's Polson Bay, Flathead River, the Mission Mountains, the Swan Mountains. A little different than our usual perspective. The surgeon's usual perspective of the heart is that. The patient's perspective after heart surgery has heretofore been that. unless we confer significant benefits so the patient forgets that they're healing that for the first 6 weeks, that can dominate. We have, because of those things, and if you go back here, I'm sorry, this is where the heart sits, and you can tell that it's a bit awkward to get to. You've got to get either through or around those ribs to get access to that heart if you're going to fix it. Now, we've made some efforts. This is actually heart surgery through a smaller incision. This is our current usual incision. This guy is about 2 weeks out. The old incisions went higher and lower. And as these incisions have gotten smaller, lo and behold, surgery outcomes haven't changed much, and healing time and complications seems to get less. And to that end, many people have pursued heart surgery through non-sternotomy incisions, meaning don't cut the breastbone. And some people have found that these advantages can be conferred. The question is, how can you get there? Well, it's really interesting. The robot we're going to talk about is named after the guy that drew that picture, Leonardo da Vinci. This is kind of a cool book, Leonardo's Lost Robots. And actually, back in the 1400s, Leonardo not only designed but built some mechanical robots that have been reassembled from some old notes. And I think there's an exhibition of them in San Diego right now. Obviously, a Renaissance genius, but this robot we're going to talk about was named for this guy who thought about these things 400 or 500 years ago, casually. Most of us, when we think about robots, think about this. Anybody recognize this one? So I was, I don't know, maybe not born yet when that program first came out. No. Lost in Space? Does anybody remember the name of that robot from Lost in Space? I don't either, but Angela Cartwright was about my age, and she was really cute. And I didn't like that robot, but by God, I watched Angela Cartwright talk to that robot. This, I swear to you, was my 7th grade. I promise. That's R2-D2, and that is C-3PO, and those are most of our thoughts about robots. This robot that we have is a little different, and if any of you walked by the robot out there, it's a weird thing. It's not really a robot at all in terms of what we think. It is a robot in that it's a mechanical device that allows us to translate motion elsewhere to motion inside these instruments. And this robot was actually first conceived of as a battlefield robot that a remotely positioned trauma surgeon could, by means of telemanipulation, operate very close to the field of injury. And that was the concept, and it has not panned out for battlefield use, but it has panned out for surgical use. And if you look, this picture over here is designed to give you an idea about how small these instruments actually are. The instruments themselves is right here, from this piece to that piece. The rest of it is a shaft that allows us to get access and move it around and houses the cables that move that. Here's a pretty good picture of what this thing can actually do. Its range of motion far surpasses that of the wrist. These are wristed instruments that mimic the hand. They can flex twice as far as a hand can flex. They can rotate 540 degrees, which is 1.5 times around. And if anybody wants to try that yourself, it's not that simple. This is a mock-up. This is, we have a little model out there that mimics a normal-sized human's chest cavity. These are the ribs. These are the robotic arms. That's where the heart sits in relative position. And so with those thin instruments, we can translocate a wristed instrument, so the thin shafted instruments, translocate a wristed instrument inside the heart or inside the chest. And those incisions are about as big around as your index finger. This is how we control them. This machine is a Da Vinci robot. It's out there. You can see that, and you can actually try it if you want. Here's the big picture of a thumb and a forefinger sit inside this console, and then the robot translates your movement into the movements of the grasping instruments. This is a setup for mitral valve here. So rather than a sternotomy, you can see that there's 4 in this picture. Generally, there'll be 5 working ports. Each of those ports is about big enough to admit your index finger. And this port is a working port. It's bigger than that. This picture to your right is a picture of a patient post-operatively. Those are 3 operative ports. 1, 2, 3. And that's where the robotic arms went. This is access to where the anastomosis, or the connection between the blood vessels, was made. And this picture here is an angiogram to show you that despite all the glitz and sex of incisions, we still have to achieve something worthwhile to the patient. And that is, this is a connection of a blood vessel on the right. That's the connection of the anterior descending coronary to the patient's native and blocked coronary artery, and it's proof that that anastomosis is open and working. The idea behind the robot is that we can achieve results. This is a picture of a coronary angiogram, but results that are the same as or better than open results for the technical repair through incisions, which are far less disturbing to the patient and easier to recover from and less risky. The charge for us is to do this in a way that's responsible, financially responsible. It's a $2 million gadget. $2 million for our town and our hospital. That's a lot of money. So it's got to be financially responsible. How do we do that? How do we make sure that that investment isn't wasted? Well, we learn how to use it in a responsible way. We try and convert it into the benefits of our patients who trust us to do so, and we learn it so that our assumption of the new technology doesn't put us back to Hippocrates bleeding somebody for presumed medical benefit. We take that very seriously, and we have our team, a group of nurses in the operating room. Shelley is here right now, one of our nurses whom we rely on greatly. We have a group of people who are dedicated to this idea. My partners are dedicated to it. We're going through a curriculum and a practice sessions before we try it to apply it to patients. And we're going to have a proctor from outside to come in and make sure that we have all the tools at our disposal to ensure that we do it well, that we don't add any injury to our patient, and that we confer both the aesthetic and physical benefit as well as the technical benefit of the operation. This is perhaps the world's most famous physician. That's Michael DeBakey, who pioneered aortic surgery, especially dissection, who has one of the most fascinating stories in all of mankind, in that the man who described and pioneered the repair for aortic dissection or tear at age 97 would diagnose his own tear, decide not to get operated on, sleep and wake up in his house, and after becoming delirious, his wife and his partner decided to have him operated on. At that age, he spent months and months in the hospital, but ultimately recovered, only to die at age 99 about a year and a half ago. But that is the old operating theater. This potentially is the new one. And the transition we're designing, we hope, is going to be safe and confer benefit and serve our communities and our patients. Thank you very much.